Thank you. So we will move on now to the next presentation. It is by Mr. Deepak Agarkhed. He is the General Manager of Engineering Services at the Sakra World Hospital. And he is a qualified engineer and an MBA with a master's degree. He has 25 years of experience in healthcare delivery, and he is a technical committee member of NABH and also a technical assessor of medical device at NABL. So I would like to welcome Mr. Deepak Agarkhed for his presentation. Thank you.
Slide change. Okay. And for the video? When I tell it. Good afternoon to everybody. I'm Deepak from Sakra World Hospital. My presentation is basically focused more on the medical device. So all of the sessions which we had discussed probably on what are the safety precautions, what are the evacuations. But since my background is from the medical equipments, so I'll be stressing more on the medical devices, what are their roles in case of the fire, and what are the things which we need to do to prevent the hazardous conditions. Let me show a few of the clips. 5 babies killed in incubator which caught fire. This is a news which has come. Similarly, a cardiac arrest following the ventilator fire. So these are some of the incidents which we do hear from the newspapers, media. But we fail to understand why it has happened, what are the root cause, how it can be adopted in our setup so that we can avoid these kind of incidents. So this is one of the point which I would like to stress upon in the presentation. With respect to the medical equipments are being classified as per American Institute of Architecture as fixed medical equipments as well as movable medical equipments. Fixed are basically they are grouted on the facility, and they are connected to the various services, like for example CT scan, MRI, the gamma camera, linear accelerator, etc., etc. Movable equipments are those which are being used across the hospital, and they are being connected to the patients, but they can be transported, like a ventilator, portable ventilator, which can be moved from one place to other along with the patient. So we need to understand what are the conditions when the fire is been caught for a fixed equipments, what need to be done, what is to be done for a mobile equipments. This is the sectional view of the hospital. Any of the tertiary care hospital, you will have the emergency, you have the diagnostic setup, you have the wards, you have the OTs, ICUs, and various facilities which are around. Now, typically in any of the hospital, 33% of the assets are basically medical equipments. You can see in the picture everywhere, all the clinical areas, medical equipments are located. So medical equipments, do they contribute to the fire, or do they act like catalyst, or is there anything which starts triggers with the medical devices? This is something which we need to understand as a part of this presentation. Unfortunately, in India, we don't have the standards for the medical equipments. So if you see go to USA, any equipment which is to be sold, it has to have a FDA. If it is in Europe, it has to be CE mark. But in India, we don't have a standard. It means you can get all sort of equipments from various countries, or it is manufactured in India, but without meeting the criterias, which may compromise on the safety of the equipment per se. So what need to be done? So we, as you know, you may be knowing through media, currently around 23 medical devices are being approved. Only last week, 4 of the medical devices which are commonly used, like a glucometer, thermometer, BP apparatus, have been approved by the government, so that any of the new products which are going to come, there is going to be some screening which is going to happen, so that the standard can be maintained. But till then, what need to be done? We need to have a proper pre-commissioning check for the medical devices. Very important. If you don't take all these inputs, then you may end up in a situation wherein the device is being partially functional, device does not have the safety features, device has not been properly commissioned. There are instances where in a third world country, the same model of the equipment which has been sold in abroad is been sold at a lower cost, but it may be refurbished or some of the compromise has happened. So this is very, very important from a hospital perspective, that equipment pre-commissioning checklist is there, and ensure that these things is been done as a part of your sales agreement, so that you will be sure that the equipment which has been commissioned is safe to be used. This is a live example of one of the hospital wherein when I went for a survey. So it's a console room. So in a hospital scenario, most of you are from a hospital background, I need not have to tell. For a major equipments where the technician who is sitting in a console room and the patient is in the equipment room or a gantry room we call. So you can see the console room, it looks okay, but if you see below how many extension cords are there, how many cables are lying, there is no cable management. I'm not talking about any of the government setup. I'm talking about the corporate hospitals. So if this is the condition, just imagine where the management is not strong, what is going to be. So these are some of the important things which we need to look into when we are actually talking about the safety. Major issue which comes because of the medical equipments is electrical hazard. You can see electrical hazard, which because of the one incident which initially I talked about, we draw a power from more than what is required. The cable, the capacity is not there. So it is in an oxygen enriched environment. So these all things will lead to ultimately a fire or a mishap. So electrical hazard is something which we need to look into when we are talking about the medical device. This is a scenario of any patient who is in the ICU. Lot of medical equipments which are been connected. So the patient is not in a conscious condition. The nurse comes and sees the patient and goes. But you can see so many equipments are being connected. On average, around 12 to 14 electrical sockets are being used when the patient is on ventilator, when patient is critical. So it's absolutely necessary that the safe conditions are maintained. This is another scenario. You can see the operation theater, wherein you have the multiple people around the patient in a surgical site. You have the wet condition in some of the operation theaters, like in the orthopedic, and you are using some of the equipments which are electrically operated, some are pneumatically operated. So there is a chance that we may end up in a situation which can be prevented provided we take some measures. So one of the things which can be done during the planning stage is when you are talking about an ICU, you can have the booms we call as pendants. You can have in a ICU setup, the patient is there, you need to use the IV lines, you need to use the syringe for dose infusion. You also need to have the medical equipments like a ventilator. So you can segregate a wet portion and a dry portion. So that wet portion is being segregated so that all the equipments related to wet are being at one place, and dry, like the ventilators, are being kept at other, so that you are trying to segregate from the beginning. So this is something which can be thought of when you are planning for the medical equipments at the planning stage when you are commissioning any of the hospital. Later on, it's very, very difficult because you have to move, all the services are coming. The services are medical gases, services are electrical, services are the the IT lines which are coming. So it's better that we plan in advance so that we are safe from the infrastructure per se. Similarly, the bedhead panels. So you can see the bedhead panels in most of the hospitals. You need to follow some of the standards like HTM 2022 standard, wherein we in the head panel we segregate the electrical sockets from the low electrical points as well as the medical gases. So what are the major reasons for fire hazard when used on the medical device? Poor facility design with no consideration for future upgradability and adding extra electrical extension cords when need arises. I'm fortunate to be a part of the planning and commissioning of the 4 greenfield hospitals. Every time I do face the challenges of this. When we plan, we talk of all the points, but when it has been delivered, it will be 80% of what has been planned. And when it has been practically used, so you will have to deviate from what has been planned. So it's very, very important that we plan, execute properly, and implement it also. If we don't implement, we'll still find the extension cords which are in the various places. Loose connection within a vertical column or horizontal bedhead panels. The horizontal and bedhead panels and vertical columns need to be maintained also. But the people don't care for those things, although they are being used heavily. So we need to have a maintenance schedule for those things. Bypassing the safety precautions like overriding the MCBs. This is something which people try to do as a shortcut, which should be avoided at any cost. Then substandard power cords from unauthorized local suppliers. This is some incident which I have come across in my experience, wherein one of our purchase team said that, okay, we cannot take the power cord from the OEM, very costly, we go for the local. And it was not even known to the clinical engineering. So later on, in one of the ICU, there was a spark. And then when the root cause analysis was being done, we realized that whatever the cord which was being taken is a cheap, and it breaks very brittle, and it does not even sustain the power which is passing through it. So we should not bypass. So what are the points which have been given by the OEM? Similarly, there are some instances wherein for a medical device, what is being done is, okay, the equipments are battery operated as well as the electrically operated. The battery supplied by the OEM is X cost. So in order to show some cost saving, the people say, no, we can do it locally, and this is how it is going to be done. But we don't know when it is going to be used and what is going to be the impact of it. Unsafe practices like equipment disconnected from a power cord, but live cord lying on a wet floor. This is something which has happened in my own hospital. In one of the ICU, the equipment was being disconnected, but the power cord was still with the bedhead panel. And there was a wet condition, there was an instance of fire. So these are the things which are practically happening. So we need to, as a clinical engineering department, along with the safety team, should ensure that these things are being avoided. So oxygen enriched condition within the OR, which I'm going to talk about in detail. So, but these are the major reasons which I have come across for the hazards which on the medical devices. This is a slide from a FDA site. You know that medical equipments, you may be knowing that the cars, when the cars are having a problem, globally they recall. Toyota recalls, Ford may recall. So what they happen is, they ensure that all the cars come back to their factory or to the dealer and they do some modification. It is true with medical devices also, but the knowledge is not there with the people. People never know that there are recalls have happened. They are using it because in India the regulations are not strong. So we need to at least see the FDA website on a regular basis. In fact, I introduced this standard in 4th edition NABH for recall of the medical equipment. So at least those 500 plus hospitals who are NABH accredited can ensure that the equipments are being checked on a regular basis and recalls are being notified, and we take it from the clinical usage. Unfortunately, the service providers, they don't voluntarily come and say there is a recall. They feel that, okay, if I tell, there is a possibility that my equipment may never be taken. So this is something which need to be done. So whether you are an accredited hospital or non-accredited hospital, please check whether in the FDA website you can access, you can see which equipment is recalled. It gives year-wise, the equipment-wise. So let us come to the surgical fire. As I told you, the operation theatre is a very complex environment. I'm sure in the morning sessions, some of the people might have touched upon the surgical fire, but there are three major players who are actually helping to get the fire within the system. So one is a surgeon who is using the ignition source, like he's using the electrosurgical unit. He may be using defibrillator as and when there is a patient has a problem. Fiber optic light sources are being regularly used to focus when we are doing a surgery. So these are the ignition sources. Anesthetist is basically involved as an oxidizer, because you have an anesthesia ventilator. It is connected to the oxygen, N2O and compressed air line. And nurse involved with a fuel like surgical drapes and preparation agents. So we need to ensure that certain things are being done, trained to the people, so that we prevent the fire. So enriched O2 and N2 atmosphere can vastly increase the flammability of drapes, plastics, hair. So be aware of possible O2 enrichment under the drapes near the surgical site. Sometimes it so happens the patient SpO2, oxygen saturation level, starts dropping. So the anesthetist starts putting more oxygen. But you need to see whether at that time the surgeon is using the cautery machine. So all these, that's why it's called operation theatre. So there is a coordination among the various people. So coordination is very, very important for preventing the fires. Fiber optic light source. So earlier I was also wondering how the fiber optic light source can contribute, because some of the things we have not tested because we cannot afford to test it. But there are luckily some of the institutes like ECRI, they do send the videos on what are the things which have happened, and they have a simulation conditions. So fiber optic light source can start fire. It has for 300 watt the xenon light source with a fiber optic the cable, so which of a 1 meter. So if it is not been when it is not, machine is not in a standby mode, and if you take out, so it's in an oxygen enriched environment, it may lead to a fire. The biggest challenge is with the electrosurgical system, cautery machine. The cautery machine, so wherein you are using for the cutting, coagulation, so you are actually using the RF current, and if it is not been properly taken care, it may lead to an issue. The biggest, more than that, the biggest challenge is to convince the surgeons. This may lead to a problem, so please take some of the measures. We have some challenges where there are some burns, but the surgeons refuse to change their practice. This is one problem which we face, but we have to tactically handle so that they will not make the mistake. Defibrillator, it may be used once in a while, especially in the cardiac OT where the patient has an arrest. But when you are giving a shock, you are using 360 joules. So there is a possibility that it may be not been pressed properly. It may have been put on the ECG cord, so it may end up in the fire. So these are some of the points, finer points I would like to touch upon. So probably per se may not be applicable to you people. Maybe you are from the safety and security background, but it's worth knowing because in the operation theatre, this is happening day in and day out. So how to prevent? Remove the unneeded foot switches to avoid the accidental activation. Use electrosurgical unit in a standby mode. whenever you are not using it, because you are actually firing, so then on the tip, so there is a RF current flowing. Never use ESU in close proximity of fuel in oxidized enriched environment, which I was talking about. Fiber optic light source I was talking about. So we have something called as a gas scavenging system, anesthesia gas scavenging system. Basically, it sucks out all the anesthesia gas and takes it through suction and goes as an exhaust. So we need to use the anesthesia gas scavenging system at an appropriate time. Be aware that alcohol-based preps are flammable. So these are the some things which we need to give as a training to our entire staff, clinicians, technicians, and the nursing, so that we can prevent the fire. How to respond? So maybe it has been touched upon in the morning session, but I would like to, if it has been touched, I can skip. So please let me know. Or should I continue on this slide? Okay. So we divide this has been basically, the content has been taken from ECRI. The small fire, so which is there due to the electrosurgical unit pencil, so extinguished by patting on the fire with a gloves hand or towel. If it is a large fire, stop the flow of the oxidizer to the patient. Remove the burning material from the patient and extinguish them. Care for the patient. Then if evacuation is needed, disconnect the patient from the devices, because so many devices are connected. You are connected syringe pump, infusion pump, you are connected anesthesia ventilator, so you have the plate for the electrosurgical unit. You have to disengage those things. Then only you can take out the OR table. Then close the OR door, shut off the medical gas valves, auto AC damper to prevent the ducts from smoke migration, electrical powers to be switched off. Then evacuation to be done in a pre-planned area, having a provision to handle surgical patients. Right fire extinguisher should be used. So these are some of the steps which are needed for the evacuation. Now coming back to the fixed equipments. So the fixed equipment, this is a scenario in one of the hospital wherein we have the UPS which has been connected to the medical device, fixed medical device. Here in this case a CT scan. As a design, there is a separate console room, separate gantry room and separate UPS room. And it has been secluded, the walls are secure, the fire precautions have been taken when we are building the walls. Everything has been done, but see the adherence. You can see the cardboards, it has been completely messed up. So it's very, very important that we as a team ensure that sustenance has been done. So the regular rounds are must, and we need to not compromise on this, because the fire is such that it may happen once in a while, but when it happens, it's a catastrophic condition. So some of the do's and don'ts for the UPS batteries which are been there. Keep the batteries away from the heat, sparks, fire, clean the batteries, and when they and ensure that the cables are being proper size and clamped properly. So do not tamper the safety walls. Do not allow any metallic objects to fall across. Do not allow direct sunlight. So you will find that in a hospital, there are the central UPS as well as the UPS which are used along with the medical equipments. Please ensure that these things are being taken care properly. One of the important thing which I would like to touch upon. So being a part of the Toyota hospital, safety is a very passionate thing for our promoters. So when they talk about if any incident, we have to do a lot of root cause analysis. One of the thing is implementation of a 5S. 5S is basically, you may be knowing, but I would like to touch upon, sort the things so that whatever is needed is been there, what is not needed should be taken away. Set the things in order so that properly daily things, weekly things, monthly things are being kept based on the location. Ensure that they are being properly cleaned. Then it has been sustained, because hospital is 24/7. So every shift the people keep on changing. It should not happen that one particular item is needed, it's not been available. So this should not happen. And then finally sustain it. This is something which I take an example every time when I talk about this, about my mother who is here, luckily, and when she maintains the kitchen, 5S has been adopted. Why can't we adopt 5S in our areas? So this is something which is not a costly, but it takes out a lot of clutter and ensures that so this safe environment condition is there. So this is some of the example 5S which has been done in our hospital. So fixed equipment, when the fire occurs, what need to be done? Equipment function must be understood by the team, very important. You have different set of application for different equipments. You may be wondering, so this is a CT scan. I'll show the next slide. Okay, this should have been a MRI, but I have put CT scan only here. I'm sorry for this. So CT scan and MRI, they look similar, but functionally completely different. So this is something which you may be surprised. We have something called upkeep campaign in our hospital. Every year we do it. And in one of the survey, we sampled around 25 members and we told them that, okay, please tell the difference between the CT scan and MRI. They were not able to tell properly. So MRI, it's on a strong magnetic field. So to enter into MRI, a person should be away from the magnetic things. So you need to, when there is something mishap happens, we need to ensure that they are being evacuated properly, and MR compatible fire extinguisher has to be used. So this is something which need to be done, known. There are some safety switches which are located with the equipments, especially fixed equipments. You need to know these are being properly understood by the people. One point I would like to tell about a safety switch which is there in MRI. The one which is there is about MRI is also been shown. A safety switch is there. The safety switch can be used only when it is needed, when somebody is stuck. Because when you use that safety switch, magnet loses the power, it quenches. So again, to ramp up the magnet, you will have to spend at least 1 crore. So the people have to know what is the significance of each of these safety switch, when it is to be used, who has to use. So these are some of the points which may look very, okay, what is this silly, but it is in practical condition very, very relevant. So this is something which we need to do for the medical equipments. About MRI, I told about the MRI. Now there is something, I have only 15 seconds left now. So if I don't know whether I can extend for another 10 minutes. If not, otherwise I can skip. Okay. Yeah, 5 minutes. Okay, fine. Thank you. So this is about the risk assessment. So this is a tool which has been used in Toyota called Anzan. So wherein we try to understand we can predict the risk and what are the things which need to be done. So you all know hazard is a potential source of harm. Harm actually happens. Risk is a combination of probability of occurrence of the harm and severity of the harm. Safety is what we all look for. So unsafe conditions can happen because machine is defective. In the second slide which I shown, the ventilator was defective. Internally, it has caught the fire. Material may be defective. You may use the substandard, the accessories for the equipment. There is no standard operating procedure how to use the equipment. Environment is not proper. Unsafe act is also so people are lacking the knowledge, lack of experience, lack of intention to use, human factors which are there. So if you have an unsafe action and unsafe condition, you can see what is going to happen. This combination is very fatal. So we need to avoid both. So it is necessary that we follow proactive risk assessment, which in NABH we call HERA, which has been explained by the previous speaker. So we need to ensure that we do we call FMEA, failure mode effect analysis, but we have a technique which we called as Anzan technique here. I don't have much time. I'll quickly tell you what exactly is there. It's basically wherein we try to assess the risk. Something called a KY technique is been there, and we go through that. Then we suggest something to the top management. Then top management will give green signal. Then the middle management will ensure that it's been done, and the lower people act on it. So there are 4 steps. One is a 2S, one is a KY, one is a risk assessment, then work instructions. So 2S I have already talked about 5S. So the first is sort, second is storage. Then KY is a danger kikin yochi, it is called as in Japanese, danger prediction training. So basically, so there are various techniques of KY. But one of the thing you can see with one of the bar graph, the percentage of making of the mistake. This was been source of Railway Technical Institute of Japan, wherein they say that by pointing and calling something, your percentage of mistakes will reduce drastically. Only seeing by eyes is 2.4%. They had done some study. So the kick in yochi is basically done like this. You can see here, whenever the surgery is happening or whenever the count is happening, so the nurse is telling, is it okay? This count is okay? She says, yes, okay. So in this way it has been done. So here is a condition. Your patient is in an ICU. So there are various risks which are associated. One of the risks you can see, the extension cord is there and a wet environment is there. So the which is very high, the combination of wet flooring and the movable live electrical, it may lead to a short circuit. So I don't want to go into this, the time is short, but the technique is, I'll show you, the tool which has been used. We try to see frequency of occurrence of the hazardous condition, how frequently it occurs, evaluation of accident severity, and evaluation of occurrence possibility. Based on that, we get a matrix called risk evaluation. This risk evaluation will decide how serious it is and how soon we need to act on it. So this is something which need to be done on regular basis. In fact, I'm happy to say our fire and security team is here among us, and they have done this kind of Anzen technique, and they have successfully been implementing on a regular basis. So this is very simple, it does not need, so it can be used in the workplaces. So this has been done here in the patient in an ICU environment with the electrical fire because of the extension cord. So we did this, and risk evaluation matrix has come from 25 to 12. So in this way, the risk evaluation can be done. So there are other points, but the time is a constraint. So this will not end. So we'll have to later on come with an SOP, and it should be addressed by everybody, and it should be trained to them. Some designs which are related to Joint Commission, related to the fire. So good practices. This presentation probably I can give it to our security team. They can share these things. But I will take few points. I'm done. But I'm showing some of the pictures, of the live pictures when we go for an assessment. How are the conditions? And with this, I would like to close. So we talk about the accreditation, sustenance, but if we don't take a day-to-day actions, so we may end up in scenarios like this. So it's very, very important that we follow the guidelines which are been given in the NABH, and good practices to be followed so that we are safe from the risk per se, from fire in particular. With this, I would like to conclude. I thank you for giving me an opportunity. And if any questions are there, welcome.
My name is Dr. Purata. Doctor, extremely interesting. I made some points and some notes I think will be useful to most of the crowd here. I just want to point out a few key words that you used in the presentation. Cable management, power cord in wet condition, loose electrical wires, adherence, cardboard boxes, regular rounds. In case of UPS, it was direct sunlight.
Yeah.
You have used the word upkeep campaign. You have used the word predict, frequency, SOPs, the 5S, and you have taken
Correct.
and kicking your cheek.
Yes. In fact, Kaizen is one of our operating principles.
Absolutely, absolutely. Now, what I have not heard during this conference is the fact that in spite of the fact that a hospital has certain restrictions in terms of using its CCTV cameras, each of these problems can be solved if only you make optimal use of your CCTV cameras. And the earlier speaker, sir, you said, use the past to improve the future. Now, what I'm trying to suggest is, if as part of the SOP, every hospital here starts auditing its CCTV footage on a daily basis. Audit. The cameras are seeing lots of things. Maybe you cannot put a camera in the OT, but wherever a camera is possible, please start seeing what the camera saw. Very simple. You will start discovering things. Please start a standard operating procedure of incident reporting in a standardized format, which starts giving you predictions. So you will know that on floor number so-and-so, on every Friday, between 3 o'clock and 4 o'clock, you have a certain type of problem. Please start using video, not losing video. Don't make video as fit and forget. This is my suggestion. Thank you.
Just to answer your question, in the hospital, one of the hospitals in Bangalore, many patients were dying in the ICU. Why? The reason was the cardiac, this was being disconnected by the nurse, and she was charging a mobile on that socket for the UPS. And that was captured by the CCTV camera.
Drawing point proven.
Yeah, these are very common practices which are there. So strict vigilance is very, very important.
Use it.
Yes, we need to use it.
Wait for things to go.
Yes, agree, completely agree with you. Yeah. That's it.
I think it was a very good presentation. I think Kaizen and these concepts probably will go a long way in improving the hospitals in this country, and how we can incorporate this, I think, is something that we all need to look into. So thank you very much, sir, for the presentation. It was very insightful. I would request Mr. Dominic to do the honors of giving a memento and a bouquet. Yes, sure, yes. So we would request Mr. Deepak's mother also to join us on stage. That was a special request from Mr. Deepak. Can we have Mr. B.K. Prasad accompany the lady? Can we have a round of applause, please?
You should be a proud mother. So, on behalf of your son, I'll give it to you.
Thank you, sir. So now over to Dominic for the PAC and FSAI presentation. Thank you.
Nice to see mother accompanying son as a speaker, and it's what a motivation that son gets to see, son talking about saving lives of the patients. And can I call our international president, Mr. Pankaj Zakar, also to come onto the stage? Is he here? Yeah, is he here? Ladies and gentlemen, I would like to present the Asia's biggest show that's going to happen in February 28th. You're all here because you are interested in